So before I dive into, the details of Adaptivo and epidosimetry, I just wanted to make everybody aware that there are a lot of resources out there now to help you make the transition and recognize the value of epidosimetry for your practice. Most recently, or at least about just over a year ago, AAPM Task Group 307 put out a report that is really useful. It provides guidance and recommendations for the use of epids for patient-specific IMRT and VMAT QA. And that's not just for pre-treatment QA, but that's also for during treatment epidosimetry. It does a great job discussing the strengths and weaknesses of epid dosimetry panels as well as epid dosimetry solutions. And it provides wonderful recommendations for commissioning, validation, and routine QA for your epid dosimetry program and systems. Now, there are strengths and weaknesses with epid technology, amorphous silicon epid panels. Two of the great strengths are really image resolution. You can't beat the image resolution of an epid panel. No other QA device that external to the LINAC has similar resolution. Also, it's so easily integrated into your clinical workflow from a pre-treatment QA perspective as well as for every fraction. Now, of course, we all know that there are some weaknesses of epid panels and their dosimetry. First, there is an energy dependence. There's also a field size dependence that is more particularly there for higher energies. You do have to consider backscatter. There can be potential issues with positioning of the panel that could be sag with certain gantry angles. There are, of course, field size limitations. The panel has a set size, and then there's a collision potential for certain treatments. So you have to be certain as to what treatments that this is applicable to. However, the good news is software solutions and the commissioning process for your epidosimetry system can account for most of these issues. Just to clarify here, there are, for Adaptivo's epidosimetry, it utilizes transit dosimetry. So with the patient in place on the table for treatment, the epid panel measures the exit dose coming through the patient. So Adaptivo really does a great job allowing you to leverage your epid technology that's already existing on your accelerators, and then bundle with that data and automation to really allow you to optimize treatment quality throughout your treatment. As I mentioned, it's daily epid exit dose tracking during treatment. And today, like I said, I'm going to just focus on the In Vivo module. We do have a pre-treatment module, of course, that measures the epidosimetry without the patient in place. And then the 2D In Vivo module is during treatment. So the In Vivo module is able to capture setup and delivery errors, plus changes in patient geometry. So that's weight loss or tumor size. And I'll show you examples that illustrate that today. We have two different modes within this In Vivo module. There's a predicted mode, which compares the daily epid image or portal to a calculated adaptive beam model image from within Adaptivo. And then we also offer a relative mode for those beams that you don't have a commissioning beam model for in Adaptivo. And that allows you to select a reference image, could be day one or any subsequent image. And then it will compare subsequent imaging after that to that particular reference image to give you a baseline. So you can still look at trending. More of a generalized high-level overview of some of the visuals and the data presented in the software. I'm just going to kind of show you briefly this image. So here, this is how it would look for a particular patient plan. And as the fractions are delivered, you have the epid image analysis results shown here visually. You can see here, it's a small image here, but you are able within the software to dive in deeper and make this bigger and investigate each of these in much more depth. But for today's purposes, I'm just going to show you this level and we'll look at trending. So here you can see you have the gamma results associated with each epid image analysis. And of course, it's the standard pass, caution, fail alerts. And these alerts can be set and customized within your clinic based on sites that you're treating and whatnot. That should be something that you devise that meets the needs of your particular clinic. So really overall, having this kind of data trending does improve patient care by allowing you to proactively manage your treatment quality and risk every fraction. You no longer have to be blind to the fact that you did pre-treatment QA and everything looked good, and you're just assuming that setup and delivery was also good. I'll show you a great clinical example where they were able to quickly identify a setup issue and ensure quality as they move forward. Again, all three examples will show you easily to interpret visual trending, so you can kind of see what's happening over time with your patients. And all of this allows you to increase efficiency and improve confidence in your deliveries every single day. This graphic will just show you how all of our devices and solutions fit into the clinical workflow. So of course, every patient who comes into radiation oncology will start with treatment planning. So they have their CT simulation, contouring happens, and followed by dosimetry planning. And then it's ready for pre-treatment QA after the plan has been approved by the physician. So pre-treatment QA, of course, always has to involve some sort of secondary check. We offer I'm Sure 3D. And then for VMAT and IMRT complex cases, pre-treatment QA is usually warranted. So in this case, Adaptivo could be used for pre-treatment QA. And both of these are automated workflows. So as soon as the dosimetry plan is approved and exported, both I'm Sure 3D and Adaptivo will see that export, grab it, do the calculations and comparisons, and if necessary, send alerts to physicists or clinical staff so that they know that there's an issue that needs to be addressed. Once everything is addressed and looks good, it's ready for treatment. And as we know, traditionally, this is kind of where more active QA tended to stop, and it was more passive QA on a weekly basis. Physicians review cone beam CTs on a daily basis, but that can be a subjective process. So really, it's time for radiation oncologists and physicists to really look at the potential of automating some in vivo quality and risk management downstream. And with standard imaging, we do offer two solutions. On the treatment side, we offer our LINAC-View log file-based solution, and Adaptivo that I'm talking about today is our in vivo epic dosimetry solution. Now, both of these can work hand in hand, and I'll kind of show you how some of our customers who have both of these use those in their quality management and decision process. Again, this is a very automated process. As soon as the patient receive their treatment, both Adaptivo and LINAC-View will grab the data they need, and they will do the analysis. Now, if everything looks good, conforms to what's expected based on the treatment plan, there are no warnings, and patient set to go for the next fraction. Now, if there is an alert, for example, perhaps there's an alert from Adaptivo, the first thing most likely clinics would do is evaluate the setup. Is the patient positioned in a way that they were positioned for the CT simulation? If there was an issue, it really allows the clinicians to quickly fix that before the next fraction, and then they can see right away whether their fix actually corrected the issue. Now, if everything looks good with the setup, then you kind of take it to the next level of investigation. Perhaps something changed with anatomy and there's a need for an adaptive therapy investigation. Or if that looks good, perhaps there is something with the LINAC delivery and you might want to do a LINAC-View log file analysis to see if there's any deviation on the clinical side that is having a dosimetric impact on the treatment delivery and dosimetry. So I will go over three examples today. The first two are from one of our customers, Dr. Paul Redoff, who is in France. He's been using our system for quite some time. He does use it alongside LINAC-View. Their current practices are they acquire in vivo epidosimetry images for their IMRT and VMAT patients. They acquire integrated portal imaging at the first treatment session. They have devised site-specific gamma index criteria for head and necks or heads. Their gamma criteria is 3%, 3 millimeters, with a gamma pass rate of greater than 95%. For breasts, it's 5%, 3 millimeters, with a gamma pass rate of greater than 90%. And then all other sites, generally it's 5%, 3 millimeters, with a gamma pass rate greater than 95%. So if the analysis fails, they do have a process they go through for their investigation. The first thing that they would start with, as I mentioned, is the patient positioning evaluation. Is the patient set up, or they're using the right immobilization devices according to the simulation plan? After that, they would do an adaptive evaluation, looking at patient anatomy, weight loss, has something changed that affects the dosimetry. Next, if everything looks good with that, they may look at the LINAC failure log analysis within LINAC view to see whether there's something there that's contributing to a delivery issue. And then also, they would then do a plan analysis in the treatment planning system. So if everything else looks good on the delivery side, everything looks good patient anatomy-wise, is there something with the plan itself that isn't reflecting in the delivery? And I'll show you a very interesting example with that. So the first example here is showing the benefits of having the ability to do a proactive setup evaluation. This is a head and neck squamous cell carcinoma case. It was 54 and 66 gray in 33 fractions with an integrated boost. It was VMAT 2 full arcs. They did acquire daily IGRT 2 orthogonal KV images. Immobilization was a 5 points head, neck, and shoulders mask. The patient was stressed during their CT, and after the fact, they realized she had tended to tense her shoulders, so her shoulders were raised. In contrast, she was more relaxed during treatment delivery, so they weren't seeing this. Now, in general, they may not see these issues or have a hard time addressing these issues on the LINAC. In this particular case, for the first fraction, the therapist aligned the patient, and what they did is they tended to focus on the upper spine and didn't really pay attention to the clavicles, and the misalignment did show up as a failure within Adaptivo for both of the treatment fields. So they focused on correcting the setup issue for fraction 2. You can see here we have the red arrows delineating the clavicle alignment from the DRR, and this is the KV image. So you can see there was a significant difference here. So for fraction 2, they did a little better. They only had a single field fail at the 5% 3 millimeters criteria. The clavicle was slightly misaligned on one side still. So fraction 3, they were able to ensure the positioning was much more accurate. Both of the arcs passed. However, although the treatment fields passed, the therapists and physicists did still see a small deviation or gamma disagreement within the setup. So they really wanted to work to fine-tune this setup even more. So on the fourth fraction, they were able to truly optimize the patient's setup. The gamma analysis passed at 3%, 3 millimeters. And as you can see here, all the hot spots were eliminated. So this is a wonderful tool that clinicians can use to ensure patient setup is optimized. It's the power of data and information here really does make staff want to rise to the challenge and ensure that their setups are highly accurate. This is also a wonderful tool if you're introducing any sort of new immobilization device or setup for a particular patient that's different. It really gives you the eyes on each daily fraction that is needed to assess that. So clinical example number 2 is an interesting study because in this case, Adaptivo prompted an evaluation of the treatment plan itself, which is more unusual and something I'll kind of discuss in the end. I don't think this would have been caught with any other. Obviously, it's not caught with pre-treatment QA because that is not done within the patient anatomy. That's done in Phantom or on a device. And so I'll discuss that a little more at the end as we go through this. This is a palliative spine case. They were treating 20 gray in 5 fractions with 2 full VMAT arcs. Again, they were doing daily IGRT with 2 orthogonal KV images, and there was no specific positioning accessory for this patient. Now, the planning CT was acquired as a 4D CT, and it should have been done on the average intensity projected image, the AIP image. Now, fraction 1, we had a failure for both arcs. And as you can see, it failed at 5%, 3 millimeters. And as you can see here from a profile through one of the gamma analysis going along the Y direction here, that there is an underdose in the lower part of the field, in the inferior portion of the field. So what this did is it prompted a CBCT acquisition request before the second fraction, just to really assess the root cause of this deviation. So before treatment on the second fraction, they acquired the CBCT, and what you can see here is it shows density changes at the lower portion of the field. So this is the cone beam CT, and as you can see, the changes here are from the diaphragm movement during breathing. Now, conversely, on our planning CT, we don't have that diaphragm movement shown here. And what happened is this planning CT was a phase-based CT, not the intended AIP planning image. So it didn't account for the movement of diaphragm in here and the corresponding change in density. And obviously this had a dosimetric impact on the lower treatment volume for this patient. And considering this was only a 5-fraction treatment, it's important that we don't underdose any of these areas. So the plan was revised using the average intensity projection scan. The final 3 fractions passed gamma agreement. And really, the clinicians truly believe that they would not have identified this issue without the use of the Adaptivo In Vivo module. Had they just used their traditional, putting a diode on the patient for In Vivo QA first fraction, that very likely wouldn't have caught this issue, especially since it was localized just to one region. And of course, this isn't something, as I mentioned, that you would discover during pre-treatment QA, because that QA is not done on patient anatomy. It's done on a phantom. So you lose all of the variations in CT density that cause the issue within this delivery. So this is a really interesting, I think this really does show the value of QA for every fraction and not just pre-treatment QA without the patient there. And you won't recognize these deviations. And lastly, the third clinical example, it's a 4-arc VMAT lung and mediastinum case. And this example really shows how Adaptivo can be used from a trending perspective to find clinically relevant anatomy changes. So in this case, you can see this is trending data of the gamma results. Each of these columns is an average over the week. So everything looked good for the first 5 or 6 weeks. And then things did start trending down, and week 7 and week 8, we were seeing failure. So something really is happening within this patient, and physics was triggered to investigate. This is a shot of one of the failing DRRs. It's a hot-cold gamma over the DRR, and you can see there are areas that are hotter, and this is ended up being due to changes in patient anatomy, tumor regression, and weight loss, and I'll show you here. Again, looking at the profiles, you can see that the predicted is less than the measured. So what this is telling us is that more radiation is exiting through the patient and not being deposited where we want it to in the patient itself. So looking more closely at a cone beam CT from some of the later failing fractions, you can see here where some of the issues are. This is the treatment cone beam CT with the planning contours overlaid in the registered view. So you can see here the patient has lost some weight over the course of treatment. During CT simulation, the patient had fluid in their lungs, which has then since cleared. So we have this more air area here. There has been some tumor regression, and now that's replaced by lungs. So both of those things significantly affect dosimetry. Of course, we know that the air does not attenuate the radiation as much as the fluid and tissue. So those 3 things together really did start to significantly affect the dosimetry within the patient. And this team decided to start this patient's boost early. So really, in summary, Adaptivo does an excellent job allowing you to leverage your EPID technology, use the corresponding data and automation to really optimize treatment quality for your patients throughout their treatment process, not just through the planning and pre-treatment process. Adaptivo is really used to enhance setup accuracy, quickly identify setup issues. It really did give another level of CT plan evaluation, identifying dosimetric effects within the patient related to potential issues in planning that could have gone undetected with traditional pretreatment and in vivo QA practices. And then lastly, it really does give a quick dose impact identification of allowing you to rapidly detect dose changes due to anatomical changes and weight loss, enabling more timely adjustments. And some of these changes could be kind of overlooked in the CBCT review that's more subjective. So having this set of data associated with that really gives an extra level of quality assurance data that can be a part of the decision process for your adaptive, offline adaptive planning needs.